Alright, so lungs have got a space around called the pleural space. So this may be filled with fluids, abnormal volumes of fluids, and leads to pleural effusion. So pleural effusion develops when the fluid formation exceeds fluid removal due to pressure changes, protein imbalances, inflammation, and sometimes lymphatic obstruction. So now, by definition, pleural effusion is an accumulation of excess fluid in the pleural space. Now, massive pleural effusions are often of malignant origins. You have to note this point because I find it very, very helpful, especially when you're looking at the imaging findings of pleural effusion. Now, pleural effusion can be classified into transudate and exudate. Now, what does this mean? So when you say it's transudate, it means we're saying there was leakage of fluids into the pleural space through intact pulmonary blood and lymph vessels. So this is mostly seen in cases of heart failure. Remember this always. In cases of heart failure, other conditions may include cirrhosis and nephrotic syndrome. Now, exudative pleural effusion is due to pulmonary infections, inflammatory conditions, autoimmune conditions, or sometimes trauma to the lungs. Now, the hint that you always need to have about exudative pleural effusion is that this occurs when there's compromise to the pulmonary vessels. Remember, in transudate, we said it has to be through intact pulmonary blood and lymph vessels, but here there's a compromise. You can see we're talking about infections, inflammatory conditions, and things like injury. So cases where you're going to see exudative pleural effusion may include pneumonia, tuberculosis, malignancies, and pulmonary embolism. Now, the pathophysiology of pleural effusion is very, very simple. We just are going to look at two forces. So we're going to look at the colloid pressure and the hydrostatic pressure. So let me draw something here. So I know this is a bad diagram, but we're going to work with it. So assuming this is a blood vessel, okay, we have two forces. I'm going to demonstrate those two forces with two arrows. So this arrow going up here is representing this force here, which we're calling oncotic pressure or colloid pressure. The other one pointing down here is representing hydrostatic pressure, meaning oncotic pressure wants to keep fluids within the vessel, while hydrostatic pressure wants to force it out. Okay, so for us to maintain these fluids within the vessel, it means the oncotic pressure, which is this force pointing upwards here, has to be it has to have more strength than the hydrostatic pressure, which is the force pointing downwards. Now, when the opposite happens, where hydrostatic pressure is more than oncotic pressure, it means this fluid is going to definitely leak out of the vessel, and in this case, it's going to leak into the pleural space and cause pleural effusion. Now, there are things that you're going to see in cases of pleural effusion, and that leads us to clinical features. So what are the clinical features of pleural effusion? You're going to see dyspnea and features of hypoxia. Now, most importantly, I want you to always bear this in mind. Pleuritic chest pain. At least think of it and try to elicit it. So pleuritic chest pain is the kind of pain a patient experiences when you tell them, let's say you tell them to inspire, to take a deep breath, and they experience some chest pain. That is pleuritic chest pain. So when doing your physical exam, always try to elicit that whenever you suspect pleural effusion. The other thing is dry and non-productive cough. You're going to see a dry and non-productive cough. And sometimes, depending on the severity of the pleural effusion, you might see the mediastinum being shifted away. So this is a very, very important point that differentiates pleural effusion from atelectasis, because in atelectasis, the mediastinal shift, although I'm going to talk about this in the imaging, in the investigations, and Yes, so you're going to see a shift. In atelectasis, the shift is going to be on the affected side. So if the affected side is the left lung, you will see the mediastinal shift towards the left side. In pleural effusion, the case is different, because if the effusion is on the left lung, you're going to see the mediastinal shift on the opposite side. That is if the pleural effusion is massive. I hope that was clear. Again, as you do the physical exam, check for reduced tactile fermeters. Okay, look out for asymmetrical expansion and unilateral lagging on the affected side. So the affected side, let's say the affected side is the left side. I don't know why I'm talking much about the left side, but let's say the affected side is the left side. You're going to see lagging, let's say when the patient is breathing. The other thing is, during auscultation, you might hear a pleural friction rub. Now, pleural friction rub, just like pleuritic chest pain, pleuritic chest pain, has differentials. So you can look up those differentials. Reduced breath sounds may also be found. Then faint or absent breath sounds over the affected side. I feel like I'm talking about the same thing here. The last thing you're going to see, but not the least, is downness. So stony downness to percussion may be a clinical feature of pleural effusion. Now, when you look at imaging findings, here, I want you to pay particular attention to this, because very, very likely you may be assessed on this. So I want you to look at this x-ray here. So this image is from Kumar and Clark, okay, a textbook. Now, when you look at this side, I know it might be difficult at this point for you to interpret this x-ray, but just relax. So we're going to use simple words and language here. So the left side of the lung here, you can see this is the lung. It seems to be intact, and of course it is intact. Okay, so when you look at this point here, this is what we call the costal phrenic angle. This point here, you can see it's sharp. Okay, so this lung is intact. Okay, it is intact. Unlike the other side, by the way, this is the left side here, and then the other side is the right side. So when you come to the right side here, you find that this angle, we are not able to appreciate the angle here. So there's blunting of the costophrenic angle. That's one feature that you're going to see in pleural effusion. The other thing that you're going to see is this. Okay, you can see it has formed something like a C here. This is what we call the meniscus sign. Meniscus sign, blunting of the costophrenic angle, those are features of pleural effusion. Those are imaging findings of pleural effusion. The other thing is silhouette sign. So the silhouette sign, basically you are just not able to see the borders of the heart on the x-ray. So you can see that from this side, you can't tell to say the heart's borders are here, the diaphragm is here. You are not able to differentiate those things. You're not able to tell them apart. So that's the silhouette sign. Okay, you can see the opacification that's leading to that. The other thing that may be seen, and I keep talking about this, is mediastinal shift. Although we don't have that in this x-ray. So mediastinal shift is seen in massive pleural effusion. And remember the introduction, massive pleural effusion are often of malignant origins. Okay, massive pleural effusions are often of malignant origins. So try to connect the dots. Now, investigations. Okay, investigations which we've already started doing, of course. One of them being the the chest x-ray. We're just from interpreting the chest x-ray. You can do an ultrasound apart from that. You can also do a CT scan, and most importantly, tap. So do a pleural tap and take the fluid for analysis. So that's what we are calling Light's criterion. I haven't done Light's criteria because the video is going to be longer than this, so I'll do Light's criteria in another video. Management, just the principles of management. Treat the underlying cause. Remember, under transudative we talked about things like heart failure, cirrhosis, and nephrotic syndrome. So take for instance heart failure. The patient has heart failure, and then you keep managing pleural effusion without correcting heart failure. That pleural effusion won't be gotten rid of, because the underlying condition, the underlying cause is still there. So treat the underlying cause first. Then therapeutic thoracentesis may be done, chest tube drainage, and pleurodesis, and that is in cases of recurrent effusion. And you can do surgery in some selected cases.